Tokyolive
Endoscopy
Endoscopy
1.
1.
Well, hello. Thank you for attending this Tokyolive Endoscopy. We're at this next session, which is called New Insight of EUS Guided Interventions. And we have two excellent speakers for you that will both have their newest insight in these two topics. The first speaker is Mark Giovannini, who is well known, I think, from Marseille. He spent almost half of his life so far in endoscopic ultrasonography, but he's always been on the forefront of doing the new interventions. Mark is from Institut Paoli Calmette in Marseille, and he will speak to us on EUS-guided hepatogastrostomy. Mark, please.
Thank you for this invitation. I will put my slide, and thank you for the kind introduction, and thank you for Professor Inoue to invite me to speak about hepatogastrostomy. My first slide is about the history of hepatogastrostomy, and if you see, it's not a new technique. There was a publication in Radiology in 1994, and the technique published by Soulez was a little bit difficult because they combine a PTC, an endoscopy, and a laparoscopy. And the goal was to obtain this kind of montage with an internal external drainage and the drainage inside the stomach. If you see the paper using this technique, you see that there is a few number of patients, and this technique stopped because the morbidity of this technique was too high, with 2 deaths in 8 patients on the first study, and also 3 in the second study published by Soulez. This is the first case that we did the last century. It was using a plastic stent. It was a patient with metastasis of neuroendocrine tumor in the hilum with huge dilation of the duct, and we insert 2 plastic stent. At this time, the EUS scope has no elevator, and it was a 3.2 millimeter working channel, and it was very challenging to drain but we succeed in this patient with recurrent cholangitis. The first real publication was in 2003, and we published the first case using metallic stent, a partially covered metallic stent in this patient with a relapse of gastric cancer in the hilum. But today the technique is more easy, and this is a case of a patient with an obstructive jaundice with a previous stent, and the patient developed a duodenal stenosis due to the involvement of the duodenum by a pancreatic cancer, and you see the aspect of cholangitis with pus inside the duct. The duct are not so dilated, and the technique is to do the puncture of the segment 2 of the segment 3. This is the segment 2, and using a 19 gauge needle, and to obtain a cholangiogram. Here you see the puncture of the duct. In this case, the duct is not so dilated. It is a challenging procedure. And after we obtain the cholangiogram here, and the next step is the passage of the wire. We use normally 0035 Teflon wire, and we create the anastomosis using the 6 French cystostome. The 6 French cystostome is very useful. Here you see because you can create the anastomosis, And we can also use as a catheter to do an opacification and to be sure that the catheter is in good position in the biliary duct. And the last step is to insert the stent. Is a dedicated stent, partially covered stent with 70% covered, 30% uncovered. This is the Jobor stent. And the technique is to open the stent now in the working channel, and this prevents the so-called the candy sign and the migration of the stent into the peritoneum. And with this stent, we have reduced dramatically the risk of bile leakage. This is your decisional tree in your unit. If you have a failure of RCP, if of course the duodenal lumen is intact, we prefer to perform a choledochoduodenostomy or an anterior stenting. But in case of duodenal obstruction of altered anatomy, we prefer to perform an hepaticogastrostomy. Safety of hepaticogastrostomy. This is a recent paper on 42 studies, and you see that the main problem are the bile leakage, and because bleeding and the cholangitis we can manage medically, but the bile leakage is the big problem. Choledocho or hepatico, this is just to compare the two techniques, and you see that only this European study show that there is more complication in the hepaticogastrostomy than the choledocho duodenostomy, and this is probably due to the number of manipulation that we perform today in comparison with the use of lamps for the choledocho duodenostomy. But if you see, this is all the paper published using the hepaticogastrostomy technique, and you see the main complication is the bile peritonitis. And how to reduce this bile peritonitis, and we use now this second generation of Jobor stent, metallic stent with the large flange and the 70% covered and 30% uncovered. And this has reduced dramatically the risk of the bile peritonitis, as we have shown in your paper published 3 years ago now. And if you see in 31 patients, we have no bile leakage in this series. But the future could be this new design of hepaticogastrostomy stent is the combination of lamps in the gastric part, partially covered to prevent the bile the migration here with this part inside the bile duct, and also to use a hot system like for the lamps, and this will reduce the number of manipulation, and with just the insertion of the wire, and after we can use this system to deploy in one shot the hepaticogastrostomy. I know that this stent is still in evaluation in South Korea, but unfortunately in Europe we have the big problem with the CE mark, and we don't have access to this new stent. I spoke about malignant stenosis, but we can use also the hepaticogastrostomy for benign situation. This is the two paper published in the literature, and mainly the patient included in these studies have an anastomotic biliary stricture. And this is the case of a patient with hepatico-jejunostomy stricture after a Whipple resection, and the goal is to insert first a fully covered stent and a double pigtail stent, and 2 or 3 weeks after we remove the metallic stent, and we have a large opening, a large access to the left lobe, and we can insert multiple plastic stent to do the calibration of the stenosis. We can use also this technique in patients with stone in altered anatomy. And you see the creation of the hepaticogastrostomy with a fully covered stent. And after we can use, 2 weeks after, we can insert a spyglass to do a lithotripsy and dilation of the, this is the dilation of the papilla, and to push the fragment of the stone inside the duodenum. Malignant hilar structure. This is the last part of my talk, and we are working today how to drain the right lobe with EUS. And you know, for hepatico, for Klatskin tumors, sometimes it's easy to insert the right, the stent in the right lobe, and the left lobe is drained using the EUS route. And this is a patient with two stents because the segment 2 and segment 3 were separated by the tumor. And also this kind of patient with 2 stents in the left lobe and 2 in the right. And the goal is to try to obtain quite more than 80% of the liver drain. And we know that if you succeed to obtain this percentage of segment drain, we decrease we increase the survival time of the patient. But the bridging technique, and I will show you this technique to drain the type 2 Klatskin tumor using the EUS route. And this is the video. The first step is the same than hepaticogastrostomy with the puncture of the left lobe. Here we obtain the cholangiogram, and with the cystostome, we try to manipulate the wire using an angulated wire to pass not in the duodenum, but to pass in the right biliary system, like this. And after, with the cystostome, it's very important. We create a channel inside the tumor using the pure-cutting current, and we insert deeply the cystostome in the right system. And also we can inject contrast by the cystostome, which is very useful, and we can delineate the stenosis between the segment, the right and the left lobe. We can perform after a dilation of this stenosis, and we insert the first stent, which is an uncovered stent, 6 or 4 centimeters. This is depend of the anatomy of the patient. And the goal of this stent is to create an anastomosis between the left lobe, the right lobe, and the left lobe. And after, we open an hepaticogastrostomy to drain all the liver into the stomach. This is the insertion of the first stent. And now this is the insertion of the second stent, which is the hepaticogastrostomy. And we use a 8 centimeter jawbore in this case. Normally we use a 10 centimeter in normal hepaticogastrostomy, but in this case, we prefer to use a shorter one. And to prevent I leave in place a nasobiliary drain, and this is the final drainage with the first stent inserted in the right lobe, communication with the left, and the hepaticogastrostomy. There is 3 papers in the literature. It's a total of 25 patients. Now we have more patients in your experience. But you see that the clinical success is around 80%, but the morbidity rate is not, it's quite high, 33%. But today we have more experience, and the complication rate has decreased in your experience. To conclude, EUS guided hepaticogastrostomy is the best choice of biliary drainage in patients with duodenal obstruction or altered anatomy. New design of the partially covered stent, metallic stent, has dramatically reduced the risk of a bile leakage. And for complex biliary stenosis, combination of RCP, hepatico, PTC increase the success rate of the biliary drainage. Thank you very much for your attention.
Thank you very much, Mark, for a really excellent overview of this quite new but also quite difficult technique. So I think it's important that you also clearly explain the dangers and the risk of complications. Just a few short questions, maybe. Segment 2 or segment 3? You said, well, it doesn't make a difference. If you,
I prefer the segment 3 because we are sure that the stent will be open in the stomach. Sometimes the segment 2, the access of the segment 2 is too high, and the risk is to puncture the segment 2 through the esophagus or the junction, the esogastric junction. And first of all, we can increase the risk of complication of mediastinitis, and also it's not very well tolerated by the patient. Today, there is one of my fellow is searching if there is a difference in your experience between segment 2, segment 3. I don't have the results, but today I prefer to target the segment 3 first. This is my first choice.
And the second question is, how long what should be the part of in the stomach? How long should it be? Should it be close to the stomach wall, or maybe a little bit?
No. I think we need to have almost 3 or 4 centimeters into the stomach, because the stomach is there is a contraction, and during the first 2 days the stent is not very well anchored, and we need to have a longer part into the stomach.
I think when we did our first cases, we thought, oh, that part in the stomach is too long. But then if you come back like 2 weeks later, it's not too long. It's actually
reduced. Yeah.
I saw on your video your assistant, and the assistant, I think, in this technique is extremely important. Do you always use one assistant, or how do you do that? Because
mainly I prefer to have 2 assistants, but sometimes it's not possible. But 2 assistants is very important to prepare, because as you see, there are a lot of manipulation, too much manipulation for me, but for the reason that I think we need to have a very dedicated accessories for hepaticogastrostomy, but 2 assistant is better.
And I think it's interesting to see that in the lumps, for instance, in the common bile duct drainage through the duodenal bulb, the assistant has almost no role anymore. But for the hepaticogastrostomy, it's a very important role. So we should be careful there. In case of leakage, you talked about salvage. What do you do when there is a leakage in the abdomen? Is it just a percutaneous drain, or?
Depends. If the patient has a previous surgery, we can manage, because there is the leakage is not due to the fibrosis, it's more a collection than a peritonitis. But if it's in a cavity, if the patient has no previous surgery, mainly the patient is operated.
Laparoscopy.
Laparoscopy. We try to drain the right by PTC, but a cilioscopy or to clean the peritoneum and to have a peritoneal drainage is needed, because the bile is too aggressive for the peritoneum.
So I'm not sure whether Takao Itoi, who will be the next speaker, has questions for Mark. Takao, anything?
I know I have a question for Takao, because I know that you use mainly plastic stent, the dedicated plastic stent that you have in Japan and we don't have in Europe. What is your feeling? Why you prefer plastic stent than metallic stent?
For the benign diseases, I frequently use a plastic stent. In case of malignant stricture, for example, distal malignant stricture, we prefer the antegrade stenting and plus plastic stent for hepatic gastrostomy. And just for reintervention or keeps the root. Antegrade stenting is much better. Yeah.
But it's a special plastic stent that you have.
Thank you.
Thank you very much, Mark. Fantastic talk. I think we continue with the second part of this session, which will be the lecture given by Takao Ito. Takao, I think, also needs no further introduction. He's from the Tokyo Medical University, leads the Department of Gastroenterology and Hepatology there, and is well known, as I said. And he will talk about EUS-guided gastrojejunostomy, which is a very interesting technique, which in the past 10 years has maybe changed many things, especially palliation, but maybe also in benign disease. Takao, I look forward to your talk.
Thank you very much, Paul, my good friends, kind introduction. And also, so I appreciate Inoue Sensei for giving me very nicely the chance to talk on my topic. Okay, let's get started. I made already a video presentation. So can you see?
Yes, we can.
Hi everyone, I'm Takao Ito in Tokyo Medical University. First of all, I'd like to express my sincere gratitude to Inoue Sensei and all organizing committee for giving me this wonderful opportunity. In this lecture, I'd like to talk on the EUS-guided gastrojejunostomy. Nowadays, there are several therapies for gastric artery obstruction, GOO. Of these treatments, recently, EUS-guided gastrojejunostomy is emerging. Until now, several techniques for EUS-guided GJ are introduced. Namely, after filling the water in the jejunum, puncture and or stent placement is conducted, so-called direct technique. Balloon-assisted technique using dilating balloon, EUS-guided balloon occluded gastrojejunostomy bypass, EPAS, our technique using dedicated two large balloon. In the rendezvous guide wire technique, retrograde deployment technique, thus, so far, there is no established technique. Next, I'd like to show our EPAS technique by animation. So standard EGD is advanced in front of stricture side and using guide wire and the procedure guide wire is advanced beyond the ligament of tribes. And over the guide wire, a special balloon is advanced beyond the ligament of tribes. And two balloon inflation, and then the endoscope is advanced in the stomach. At this time, the water injected between two balloons. And they have to depict the distended jejunum, and the axis is advanced directly. Drawing the distal branch in the proximal branch. Next, I'd like to introduce our actual case. So similarly, the standard EGD is advanced in front of this structure and using guide wire and the catheter. Guide wire is advanced beyond the ligament of trides and leaving the guide wire in place, standard EGD is removed. And the special balloon, double balloon is advanced over the wire beyond the ligament of trides. And then we inflate the balloon using contrast and water up to enough size. And then echoendoscope is advanced into the stomach and to check the distended jejunum and the ultrasonography And then the axios is advanced into the distended jejunum and the deployed distal branch and the proximal branch. Usually, so it takes just 15 minutes from the beginning to finish. So this is another interesting video, the EPAS in Endo 2017 live demonstration in EAIG. So you can see a very nicely the outviewing. So this procedure was done basically by myself. So firstly, standard EGD insertion to place a double balloon placement. And the over the guide wire double balloon is advanced by myself to appropriate location and the inflated balloon by assistant. And then after occlusion, complete occlusion of jejunum using two balloons, endoscope is inserted into the stomach. Then they will inject the water only between two balloons and hot axios, they attach the working channel. And you can see very nicely distended to jejunum and the EUS. Then the hot axios is advanced directly into the distended jejunum. Very easy, like a cyst, wall of necrosis or pseudocyst, huge distended jejunum, and deploying the hot axial stent. It looks easy. This is our procedure. Very nice outcome. So PET scan shows ideal stent placement, and gastrography shows gravitatically nice flowing. Also, autopsy shows stent placement very nicely, like a surgical GJ. Next, I'd like to show the current outcome from several studies. So you can see a comparative study between USGJ and the duodenal stenting. It shows almost similar outcome, but regarding recurrence and reintervention rate, USGJ was superior to duodenal stenting. This is an international multi-center comparative study between USGJ and surgical GJ. It shows almost similar outcome, but regarding technical success, USGJ was inferior to surgical GJ at this moment, because this is an early stage of ESGJ technique. Now is almost mature. One more comparative study between ESGJ and LAP GJ. It showed almost similar outcome, but regarding adverse event rate and procedure cost, US guided gastrojejunostomy was superior to laparoscopic GJ. So lately, one study on the comparative study between USGJ and LAP GJ just published in GIE. These results demonstrated that regarding time to oral intake and to full diet, ESGJ was superior to laparoscopic GJ without any difference of adverse event rate. In 2018, several endoscopists reported EUSGJ is suitable not only for malignant gastric outlet obstruction, but also benign cases. Next, let us know the latest systematic review. The latest systematic review and meta-analysis included 12 studies with 285 patients. Technical success was 92%. Clinical success rate was 90%. Adverse event rate was 12%. And the recurrent symptom or reintervention rate was only 9%. Latest comparative study between EUS GJ and laparoscopic GJ showed EUS GJ has the advantage regarding time to oral intake, post-procedure days, length of hospital days, and the days to resumption of chemotherapy. However, there was no difference in terms of post-operative death, readmission, recurrent gastric artery obstruction symptom, and the intervention rate. Interestingly, regarding infection, EUS, and acute kidney injury as adverse events, EUS-GJ was superior to surgical GJ. Looking at cost analysis, both inpatient cost and procedure costs associated with EUS-GJ were lower than those with surgical GJ. In the aspect of presence of malignancy, there was not statistically significant in the benign group except total cost. Recently, my junior doctor just published an interesting benign case in which we observed the stent annually, stent patent annually 7 years totally by standard apogee endoscope. So you can see very nicely the endoscopic viewing 6 years after EPARS. Just the anastomotic side here. So after 4 years EPAS, the membrane of the axial stent broken and the ingrowth started. But now you can see still the open, the very nicely anastomotic side. Back and forth of scope is easy. And the gastrography showed still stent patent. And actually, the food, the going down from here. Very nice. So, ladies and gentlemen, in my conclusion, EUS-GJ using LANS is feasible and safe. Outcome of EUS-GJ is similar or superior to anterior stenting or even surgical GJ. Final answer. EUS-GJ seems to be one of options for treatment of gastric outlet obstruction. So thank you very much. Thank you for your kind attention. Thank you.
Thank you very much, Takao, for a wonderful presentation showing your vast experience in this technique. A couple of relatively short questions. Do you always use the EPAS balloons, or do you sometimes use completely freehand just by instilling water?
So my aim of perform this procedure is the 100% perfect procedure. That's why. So I always use EPAS technique.
Yes. Yes. Well, that brings me to the next question. If you don't use the EPAS technique, there is a small chance that somehow something goes wrong. What can you do as endoscopists when you have punctured the stomach, somehow didn't get into the duodenum, but probably have been burning a little while there? How can you salvage this for a patient?
You mean so distance?
Yeah, so we have somehow not released the stent because we were not into the duodenum. Can you then just try it again? There probably you will see on the EUS some water in the abdomen, or do you need to call the surgeon?
So if so, one of option is call the surgeon, but I guess just puncture and they force the make a hole, small hole by axios, only in the stomach wall. No, basically no problem. Just remove, and if necessary, the clipping. That's so we cannot find the fall. And in case of jejunal side fall, maybe I guess it causes leakage, inflammation, or some the complication at that time. So firstly, we have to place a tube. For example, the EUS tube or even ENBD tube temporary, and so suction to yeah.
Okay. How difficult is this procedure? Is this some everyone can do, or what is the volume of cases per year that you need to do to become proficient in this? So not a learning curve, but you are already experienced. Maybe I learned with you. Now I go back home. How many cases per year should I do to keep experience?
I guess once you get you run this technique, maybe after a couple of cases you can do easily. But of course, annually, but 3 years, 3 cases, no, just half of a year and the 3 cases. I guess it's okay. And one more thing, if we can use EPAS technique, in some cases very difficult because the distance between the jejunum and the stomach very far, very far. So actually, recently we studied anatomical study the major length of stomach and jejunum. Very interestingly, around 85 to 90% always cross the jejunum. The ligament of triads is very close to stomach, but 10% far from the stomach. In case we cannot use even using EPAS, we cannot do the gastrojejunostomy. 10%.
10%, you will just need to another solution.
We-
Mark,
Can I-
any questions?
Sorry. Can I ask a question?
Yeah.
If I understand you stopped to use duodenal stent in your practice, and when do you use? I understand for this 10%, but you perform a gastrojejunostomy anastomosis in all patients, even if the patient has an advanced cancer, pancreatic cancer, with when you perform the GI anastomosis, the GG anastomosis, and when you put a duodenal stent.
It is a very good question. In my personal opinion, based on the previous study, just 1 month prognosis and a lot of ascites in case we select duodenal stenting. But more than a couple of months, the prognosis or the gastric cancer, that we do this gastrojejunostomy. But in case of pancreatic cancer, even creating the gastroenterostomy may be very difficult to have the food or something.
Okay, maybe final question. Ascites. Can you just drain the ascites and then do the gastrojejunostomy, or is ascites an absolute contraindication?
Not, I don't think the contraindication, because small ascites we don't care, and a lot of in case of a lot of ascites at other times suction and also cross the between the two organs and then puncture. After that, so no problem. Actually, I showed the previous the current systematic review and the meta-analysis shows that they is described that, so no contraindication of the around the ascites.
Perfect. I think we went a little bit over time. I want to thank Mark and Takao for 2 fantastic talks, and of course Haru to invite us. And I wish you all a lot of more teaching and learning during the next days of Tokyolive. Thank you very much.